Hi guys, this is Giulia and welcome to the Neutropenic Fever lecture. What is neutropenic fever? The definition of neutropenic fever is a temperature of more than 38 Celsius or 100.4 Fahrenheit in a patient that has an absolute neutrophil count, which is an ANC, of less than 1, or when the ANC is expected to decrease to less than 0.5 in 48 hours from the fever itself. What is the emergency? Why is this important? First of all, we know that neutropenic fever is probably the most frequent oncological emergency that we have to deal with on the floor. Why is it a medical emergency? First of all, bacterial infections might show fulminant progression, especially in patients that have neutropenia. Then, we have to remember that patients with neutropenia often have very subtle or delayed signs and symptoms of localized infection, so the fever can be the only sign that they have something going on. Third very important point, the treatment needs to be started within 60 minutes, so very quickly. Why? Because the mortality, especially from gram-negative bacteria, can decrease dramatically from 70% to almost 4% with correct and quick treatment. So how do we identify patients with neutropenic fever? Pretty obvious, right? They come to the hospital, they have a fever, and their ANC is less than 1. So always check your differential in the CBC. Which ones are the risk factor for having neutropenic fever? So first of all, we're going to talk about this a little bit more in the lecture about neutropenia prophylaxis. But in general, patients that have received chemotherapy within 1 week, there will be a higher risk for having neutropenia because usually chemotherapy takes around 1 week to suppress the bone marrow. Second thing, the patients that have hematologic malignancies will be a higher risk of having neutropenia, especially if they're undergoing bone marrow transplant, because most of the times their ANC will be less than 0.1 for more than 7 days. Other risk factors that will make these patients at risk and that will make them require IV antibiotics are other comorbidities, for example, the presence of hypotension in the ED, the presence of specific symptoms, for example, pneumonia, abdominal pain, diarrhea. What is the most common source of infection in the patients that have neutropenic fever? We need to know it, but because then we need to actually treat them. First of all, we have to remember that most of the times we will not find an organism causing the neutropenic fever. But in general, the most common source of infection in this patient is actually GI tract. So it's a translocation of enteric bacteria into the bloodstream. Second most important source are catheter-related infections. Especially recently, gram-positive organisms such as coag-negative staph, viridans, strep have become very prevalent. However, because of the high morbidity and high mortality associated with gram-negative sepsis, empiric therapy for febrile neutropenia should target these organisms specifically. And we are talking about enterobacteria and Pseudomonas especially. Another source of infection that we have to think about is the tumor itself. The tumor sometimes can obstruct the lumen of the organ, for example, in the lung or in the GI tract, and that can cause a potential source of infection as well. Now let's talk about the workup. So what do we do when the patient is in the ED? Of course, we're going to go talk to him. So we get a history. Really important to know what chemotherapy they are getting. Also to know when was the last chemotherapy session, because then we can see if the patient will improve from their neutropenia or if the neutropenia is just only starting. Prior infections are extremely important because they will let us know if the patient, for example, is at risk for specific resistant bacteria, ESBL, MRSA, so that will drive our choice of antibiotics. We have to know if the patient received antibiotics recently, and especially we need to know if the patient is taking prophylaxis. We will talk again about this in the neutropenia prophylaxis lecture, but if the patient is taking prophylaxis, then we need to know what they are taking, because most of the times we will have to definitely change the regimen because for sure this antibiotics is not working. Second of all, we're going to have to stop the prophylaxis when we actually treat the patient in the hospital. Then we do a physical exam, as we do for all the patients that we see. Very important to take a little bit of time to examine the skin. Most of these patients have catheters, have ports where they receive the chemotherapy. They can be infected, they can be inflamed. We have to touch them. We have to see if the patient has pain in some of these areas. We have to look for the cubit ulcers, all of these sources of infection, possible cellulitis as well. We have to look also in the mouth of the patient, because mouth sores, ulcers can also be a cause of infection in this patient especially. Other important thing, avoid digital rectal examination because the mucosa in that area is very fragile. So in neutropenic patients, we might actually make it worse and actually help the translocation of bacteria into the bloodstream. Extremely important point that we all know, blood cultures have to be taken stat before the antibiotics, and at least 2 sets of them. If the patient has a central line, so he's coming with a central line or with a port, we should take at least 1 sample from that central line. Every patient will get a urine and also a urine culture. Sometimes even if the UA is negative in patients that are neutropenic, we will not see white blood cells in the UA, so we might need to get a urine culture anyway. Chest x-ray, technically we will decide if the patient has possible lung source of infection depending on the symptoms, but we mostly are going to get a chest x-ray anyway. More specific testing like a CAT scan, fungal markers, they will depend usually on the clinical course, and we will decide after we see the patient. Now we've done the workup and we need to manage the patient. The first and foremost thing to do is to start IV antibiotics within 60 minutes from when the patient is in the ED. The first choice usually in our hospital is cefepime. We can also do piptazo, which is dosing basically. The important thing is that we have to cover Pseudomonas. Then we can tailor the antibiotics depending on our clinical suspicion. If we think that we have a GI source, then we need to cover anaerobes. So we either do Zosyn or we add flagyl to the cefepime. On the other side, if we suspect a lung source or we suspect skin like cellulitis or a catheter infection, we might want to add vancomycin. Moreover, remember that the decision depends on our patient. So if we already know that the patient had a recent MRSA, ESBL, an infection, then we can consider starting specific treatment tailoring on the patient. If he or she is allergic to cephalosporins or penicillin, then the choice is aztreonam with vancomycin. In this case, remember that aztreonam only covers for gram-negative, so vancomycin will be covering every gram-positive, so we need to keep it regardless of the MRSA. And daptomycin is usually not indicated because it will be inactivated in the lungs, so only specific patients will take daptomycin. Another important part of the management of the patient is source control. So remember to remove catheters early when they come in the hospital. On the other side, if the patient is not improving, always remember to call ID. These patients will probably need an upgrade of the antibiotics. They will need coverage for resistant gram-positive and gram-negative. They might also need coverage for fungi, especially if they keep having fevers after 4 to 7 days. On the other side, if the patient has ongoing fevers but is hemodynamically stable, there's no explanation for the fever, there's no worsening of the condition of the patient, you do not need to change their antibiotics. For example, if the patient is being treated with vancomycin together with cefepime, but there is no indication that the patient has actually a gram-positive bacteria and he is clinically improving, you usually might take out the vancomycin after 2 days, for example. Third point, which is important, don't forget to discontinue the prophylaxis. We will see in the neutropenia prophylaxis lecture that some patients will be coming to the hospital and they will already take some antibiotics, especially levofloxacin for antibacterial prophylaxis. We have to discontinue the levofloxacin because we have to actually start higher and stronger treatment. But if they are taking antiviral or antifungal prophylaxis, we will need to continue them. Unless, for example, we are starting antifungal regimen, then the things change, but then there's going to be an ID fellow helping us out. What's the duration? So there's no specific, rule or guidelines. But in general, if we have a documented infection, so the patient has a specific gram-positive, gram-negative infection that we have found in the blood, in the lungs, then we will just decide depending on the specific infection. We also have to remember that the treatment will also last at least until the ANC is more than 500. This means that, for example, if we are completing the treatment for the documented infection, but still the ANC is less than 500, we will prolong it for 2, 3, 4 days, looking for the ANC and waiting for it to improve. On the other side, if the patient has unexplained fevers, we could not find any type of infection, we cannot find any bacteria, the blood cultures, all the cultures are negative, then there are two choices. If we know that the patient will have a quick recovery of the ANC, then we can continue the antibiotics until the ANC becomes more than 500. Or, if, for example, we think that the patient will be neutropenic for a while, but on the other side, we already treated whatever infection he had, we completed an appropriate course of antibiotics, the patient does not have any sign or symptoms of infection, then we can stop the course of antibiotics and we will just give prophylaxis with levofloxacin until the patient has an ANC of more than 500. Okay, so we are almost at the end of our talk. This table basically just summarizes what we just said. The difference between low risk and high risk is something that we don't need to know. It's more for the oncologist, because when a patient has fever and neutropenia, the oncologist will decide if they need inpatient versus outpatient regimen, but this is not something that we as residents will have to decide. So finally, let's go to our take-home points. So remember that a neutropenic fever is a fever with an ANC of less than 1. The most important thing is to start IV antibiotics within 1 hour from the patient's presentation, and the usually 7 is actually enough. Here is just a handout that you can print, and I will basically just summarize our talk from today. Thank you for listening and have a great day, guys.